Nice to be here everyone. Rebecca McEndrick, Detective Chief Superintendent and Head of Public Protection for Greater Manchester Police.
Hi everyone, I'm Andrea Patel. I'm Associate Director of Nursing for Safeguarding, so I work with NHS GM, so it's the Integrated Care Board, overseeing the 10 areas of GM.
Are our microphones okay? I take it the sound at the back is fine. Okay, great. So we were asked to just come along and talk a little bit about how we're trying to navigate the reforms from a partnership perspective. So you've heard a lot about practice this morning. There's been a lot of detail around that practice. We're here really about how do we insert ourselves into the middle of this and start to navigate through quite a complex system, or a very complex system in GM. Okay. Yeah,
thank you. So I'm just going to take you through a few slides and then I'll talk around them as we move through, just to give you a bit of a context. So most of you will know the health system in GM, but for those of you that don't, I just thought it was useful to kind of put this first slide up. So as we said, and most of you will know, we'll cover the 10 areas. There's one integrated commissioning board, an ICB, which I work for. We commission and oversee delivery of healthcare across GM. All of these areas deliver all of the health services that you come across in your day-to-day work. We've got 410 GP practices, and we've obviously got public health colleagues, 0 to 19s, paediatrics, all of that as part of that delivery. So the reason for the slide is to demonstrate that when we're looking at a system change, like we've got before us in terms of the transformation for health, as well as I know across each local authority and police, it is a massive area and a massive challenge. Each element's got commissioning arrangements, etc., and different teams, and we've got safeguarding teams in the foundation trusts and different models of delivery. So just to illustrate that for us in terms of how we move that forward in terms of transformation. So you'll be aware there's a massive element of NHS reform currently that we're working with. We've still got blueprints to deliver by next year, and we've still got new guidance around safeguarding. The statutory functions still stay with the ICB. But this, in terms of the children's reforms, gives you a little bit of background and context in terms of what we're navigating towards. So we've got the 10-year health plan that's just been published. So a lot of this model redesign happened before the 10-year plan came out. Wouldn't really be how we'd choose to do that, but we are in a space now where we've got that. We've got a strategy, etc., across Greater Manchester, and then as part of our alignment to these pieces of work, as you'll see on here, we've got the strategic commissioning plan, we've got the clinical strategy, and we've got some further work around 5-year integrated delivery plans, and our neighbourhood models. So what we've got in the context of those is the development of our operating framework. So how we're delivering that operating framework very much ties into how we'll then reform the system and transform it to lead into the children's reforms. So the neighbourhood model element, which is what's going on across the 10 of our localities, gives us a really good opportunity to also dovetail and interface these children's reforms in that space. So what does that mean in terms of our delivery of that, and how does that look if you're in a team or you're thinking about that as a strategic lead across the localities or indeed across our health partners and system? So our current model, and this is some of our thinking, it's safe to say at this moment in time we haven't got our model completely organised and sorted out and agreed. We are working through that design at the moment, and we want a core health offer across each of the 10 areas. So we're looking at a consistency of our arrangements across the 10 areas of Greater Manchester. We will need to reconfigure some services that we already commission. We want to reduce that variation across the 10 areas as part of that transformation. So they're really key areas with us in terms of that piece of work. Talked about our neighbourhood teams. It's an NHS requirement for us to develop those neighbourhood teams and the children and people multidisciplinary teams. So how that dovetails and docks into some of the work that we've got here is really crucial. So we're having those early conversations about what bits are the same, the services are delivering across all of these, so how do we do that end to end, and how do we work some of this? So currently, in terms of our safeguarding system for health across the Greater Manchester footprint, We've got that neighbourhood model, which I've just talked about, and those family hubs. So who's going to sit in there? We've got services already in those spaces at the moment. How can we look at that? Is there anything we need to develop? Are there any gaps in that? Is there any variation? So that's a piece of work that we're picking up. The multi-agency front door, we do have health practitioners in our MASHs across Greater Manchester. We commission some of that. I would think it's fair to say there's variability, and there are some areas that we could improve on that. So we have got an offer in place. And we need to think about that in the context of children's reforms and our wider health economy discussions. Multi-agency child protection teams and complex safeguarding teams. So who sits in those? We commission complex safeguarding specialist nurses. But again, we've got some variability in that space, and we've got the multi-agency child protection teams to think about in terms of how we support those and how we do that delivery. So the reconfiguration discussions are really key in this space, and obviously along with this goes our information and technology. So it's part of our 10-year plan, analog to digital, but systems talking across health is a key element to some of this reform and change. What we're proposing is that we'll have strategic clinical safeguarding transformational leads. So we need leads to drive this service delivery across the 10 areas and ensure that we've got end-to-end, so from early help right through to child protection, the right services are in the right place at the right time, and we're undertaking what we need in terms of that space. So there's some of our thoughts in terms of where we are. That's a current model, but there's some gaps in it, and we want to continue to develop that to look at those transformation leads and develop further those practitioners in the post, but we're also looking at skills and competencies and where we duplicate and where we can reduce the variation and increase efficiency. So some strategic conversations in this space at the moment. And then the last slide for us is in terms of our next steps. So our GM strategic commissioning model is the strategic commissioner for the ICB. We'll come up with that model, ensuring that we've got consistency of approach and it's aligned to future commission intentions. There's a lot of commissioning speak in that sentence, so apologies for that. I work in a commissioning organisation, but my role is over safeguarding. But that is fundamental to the approach, and ensuring we've got commissioning intentions and we've got sustainability is part of our funding and our longitudinal plan around this. So we need to ensure whatever we build doesn't disappear after 12 months or 2 years, and that's the challenge in terms of this space, using what we've got and building on it, and then how we move that forward. So the health economy system transformation. Engagement with our leads across all our providers and our areas in health, and coordinating that reform across the 10 areas is a really key part. Our NHS reforms, as I said before, also include how the system transforms. So keeping up with that, as well as the children's reform bit, is a challenge, but it's in there and it's an opportunity for us to do that. Strategic system leadership and representation at multi-agency level. So I think the coordination of that, as we move forward, we can develop further. And I think as a result of the children's reforms, though you've got your family first partnership boards, etc., but we've got GM systems where leaders come together. So how do we start to use that and navigate that a bit more effectively, or build on what we've already established? And I've talked to you about alignment to neighbourhood models and live well public health approach. So our neighbourhoods, our operating model of Greater Manchester ICB will be changing. And our neighbourhoods will work in a very neighbourhood-focused way. That sounds obvious, but there's been various responsibilities in neighbourhoods previously. That model will change, and it will align very much to focusing around the needs of the population within that community, therefore the needs of the family, therefore the needs of the child. So how we align these reforms into that work, so we've got an incorporated offer and a model, is really key to our work moving forward. So it's just to land a bit of the health conversations in the room. We haven't included the detail, but it's just to give you an idea of where our thinking is, and I suppose to be really clear that or in all your work across the localities, our offer needs to be one consistent offer across GM, and then we can build on that, as needed in a locality space.
I just want to pick up on the last thing that Andrea said, which was about our need for consistency. So GM, as I said in the introduction, a really complex system, 10 local authorities, busy metropolitan area. From the outset, GMP and Andrea, from a health perspective, we've been absolutely wedded to a need for consistency across those 10 local authorities. And for us, or certainly speaking from a personal perspective, that's the main challenge in us navigating this, and why we have tried to get into the space really quite early with a blueprint that people can build around. So this is the blueprint. It carefully mirrors health's blueprint that Andrea's just been through. It is in no way accepted or adopted as a GM agreed model yet, but it is what we are going into our conversations with local authorities and our DCS colleagues as a blueprint to try, as I said, to build around. The biggest risk for us is that certain areas go off in different directions. So speaking just from a GMP perspective, we are absolutely wedded to local policing delivery. So we have uniformed district commanders in each of our 10 districts that lead policing for their areas with the geographical and local knowledge that's necessary. We can't move away from that model. What happens in Wigan needs to happen in Tameside, needs to happen in Bury. We need to have that consistency. That's how we deliver our policing in GMP. That isn't to say that there can't be local anomalies, but they need to build for us on a consistent model, hence this. Really interested to hear some of the speakers this morning around the principles, and they are certainly some of the principles that we want to adopt within GMP as we move through these reforms. So I just want to give a little bit of an explanation around these, and then I promise that is it from us. So we want to build on some of the strengths that we already have. So it sounds odd, but I'm going to start at the high end of risk, because this is where certainly I feel that we perform really well across GM at the moment. So we have embedded long-standing complex safeguarding teams that we've had in place 2018, Jane. Yeah, so a nod to Jane Horan, our GM complex safeguarding coordinator. So in anyone else's book, exploitation teams, but they are multi-agency exploitation teams in every district. We don't want to lose the strengths that we've got in those. We want to protect them, keep them. So we've put them as part of our blueprint model. But absolutely they're at the high end of risk, dealing with exploitation outside of the home as part of a multi-agency setting. Next to it here, we've called them MACPTs. I'll probably be persuaded to change that because I realise that that's wider. We have child protection investigation units within GMP. We have the same on every single district, and they deal with our medium to severe child protection investigations. We feel that this is a real opportunity for us to make those part of a multi-agency team to mirror the model that's been put in place for our complex safeguarding teams. So they'll still do police work within those teams, but we want them embedded with partners. What that looks like exactly, which social workers they'll be embedded with, is all still to be designed, but we want to use it as an opportunity to make the information sharing much better within those teams. Moving forward, and I will start from the beginning this time, so community family hubs, some of our local authorities already operate with family hubs, and we want to really explore what the policing offer can be to that. It can't be a safeguarding police officer offer, we just simply don't have enough. But we do have uniformed neighbourhood officers, we have prevention hubs on every single district, and we feel there should be a virtual link into neighbourhood officers, prevention hubs, because that's what that part is all about, preventing it from escalating, making sure that our cops who know the local areas are sighted on families that need further support at that low level. And then moving on to multi-agency front doors, so currently referred to as either MASHs or we call them district safeguarding teams. We probably will change that name. We call them for this purpose a multi-agency front door, so as everybody knows, slightly above family hubs. We want to change the way we operate within those multi-agency front doors or MASHs. We're currently very desk-based, very process-driven, very secondary triage, which is absolutely necessary, we will continue. We're introducing automation into the police side of the MASHs, which is something we were already doing. That should start in January. That will free up a lot of officer time, and we want to repurpose those officers to do more joint visits, identify those investigations that can be easily resolved, community resolutions, go out with social workers, go out with health, and stop cases escalating into our child protection investigation units and complex safeguarding teams. So that's the model in a nutshell. What I've put at the top is an additional. So an idea for a multidisciplinary team that has a representative from each of the main partners on each of our local authority or district areas, that coordinates the families through the system, that keeps oversight, tracks, makes sure that they're not escalated for too long. That's an addition. That's absolutely not agreed. We don't have the funding at the moment for that, and I just will stress that, but we are looking with interest as to see whether there's going to be any further long-term sustainable funding from a governmental department, and that would be our answer if that funding was available, that we would want a team, a multidisciplinary team that properly tracks the cases. Yeah, I think a few other things for myself. This in no way is agreed, but we really like the model where at the front door we have conversations with partners. We don't do referrals without having conversations, that what is referred is absolutely a decision as a multi-agency, that there are daily risk meetings that stop cases escalating into strategy meetings, but those are ongoing conversations across the local authorities. I think that's it. Yeah, that's it. Yeah. Okay, thank you. Thanks for your time.